Welcome back. Today, we're doing something a little different. We're going to simulate a full consultant surgical viva exam. You're in the hot seat, the pressure's on. Let's begin.
Right, candidate. Let's start. You're called down to the ED. You've got a 39-year-old man with a painful swelling in his right lower abdomen. It's been there for 1 day. That's all you have.
And just like that, you're on. The first part of any clinical exam is all about how you handle that initial encounter. How do you start to piece this puzzle together?
Talk me through it. How are you going to approach this patient?
Okay, well, first things first, I'd perform a standard ABCDE assessment just to make sure he's hemodynamically stable. Then I dive into a focused history. I need to know everything about this swelling. When did it start? Does it come and go, or is it always there? Can you push it back in? Then I'm looking for red flags, signs of bowel obstruction, so I'm asking about nausea, any vomiting, and importantly, is he passing gas or opening his bowels? I'd also ask about risk factors for hernias, a chronic cough, any heavy lifting, and of course, I'd want to know if he's had any abdominal surgeries before.
So now you've got your history. The next step is to show the examiner how you use that information to start narrowing things down. This is all about your clinical reasoning.
Good. On examination, you find a tender, irreducible swelling in the right groin. What's going through your head? What are your top differentials?
Given that acute, painful presentation, my number one thought is a complicated groin hernia, either incarcerated or worse, strangulated. The absolute key is to figure out if it's an inguinal or a femoral hernia. The anatomy here is everything. The landmark is the pubic tubercle and the inguinal ligament. If the swelling is above and medial to it, I'm thinking inguinal. But if it's below and lateral, that points towards a femoral hernia. And honestly, I'm much more worried about a femoral hernia, because that narrow neck means the risk of strangulation is incredibly high.
But let's be real. Given the tenderness and the fact that it can't be reduced, my working diagnosis has to be a strangulated hernia until proven otherwise. This is a surgical emergency. I'd be actively looking for signs that the patient is septic, like a fever or a high heart rate, and checking the skin over the lump for any redness or changes that suggest the blood supply is already compromised.
So, the decision to operate has been made, but getting the patient to the operating room safely and properly is just as critical as the surgery itself. Let's see how the candidate handles the pre-op phase.
Let's say your examination confirms an incarcerated right inguinal hernia. It's tender, it's irreducible. What's your immediate management plan, right now?
Okay, my management will be swift. First, admit the patient and get the senior surgeon and the anesthetist on the phone right away. Second, he's made NPO, nil by mouth, immediately in preparation for surgery. Third, I'm establishing 2 large bore IVs for fluid resuscitation, especially if he looks septic. I'd also send off a full set of bloods, FBC, electrolytes, and a group and save. Fourth, I'll start broad-spectrum IV antibiotics. And finally, and this is absolutely crucial, I will obtain informed consent.
My consent discussion has to be really thorough. I'll explain exactly why we need to operate urgently, that it will likely be an open repair, and that there's a chance we might find non-viable bowel that would need to be resected. I will clearly lay out the major risks: bleeding, infection, nerve injury which can lead to chronic pain or numbness, potential damage to the testicles' blood supply, and of course, the risk that the hernia could come back down the line.
That's a rock-solid plan. Now let's move into the operating room, where technical knowledge gets put to the ultimate test.
So you're in the theater. The patient is under general anesthesia. Talk me through the key steps of the repair. What technique are you going to use?
I'll make an oblique incision running parallel to the inguinal ligament. After dissecting through the fat, I'll incise the external oblique aponeurosis, and that opens the inguinal canal. The very first critical step is to identify the ilioinguinal nerve. It's often lying right there on the spermatic cord, and I will carefully preserve it. Then I'll mobilize the cord, find the hernia sac, and dissect it free all the way down to the deep inguinal ring.
And this right here is a classic exam pearl. Stating that you'll identify and preserve this nerve shows you're not just a technician. You're thinking about the patient's long-term quality of life and trying to prevent chronic pain, which is a major potential complication.
Once I've reduced the contents of the sac, I'll move on to the repair. My preferred technique is a tension-free mesh repair, specifically the Liechtenstein technique. Historically, surgeons used tissue-only repairs like the Schuldeis, but the big problem was they brought tissues together under tension, which was a major cause of failure and recurrence. The mesh is a real game changer, because it reinforces the posterior wall of the canal without tension, and it's been proven to have a significantly lower recurrence rate.
The operation is done, but the viva isn't over. A great surgeon anticipates and knows how to manage complications. So here comes the post-operative curveball.
Candidate, it's 2 weeks after the surgery. The patient is back in your clinic. He's complaining of severe, debilitating pain right at the surgical site, and it's not responding to standard painkillers. How are you going to manage this?
Okay, severe pain like that, which isn't getting better, strongly suggests nerve entrapment, or inguinodenia, most likely involving the ilioinguinal nerve. First, I take a really detailed history of the pain and do a careful exam to make sure I'm not missing an infection or an early recurrence. Initially, my management would be conservative, starting with neuropathic pain agents and anti-inflammatories. If that doesn't work, the next step is a diagnostic and hopefully therapeutic local anesthetic nerve block, usually done with ultrasound guidance. If that gives temporary relief, it confirms the diagnosis. For those really tough cases, definitive treatment means surgical re-exploration to free the nerve or even perform a targeted neurectomy.
Of course, I'd also be thinking about other serious complications. Ischemic orchitis, which can happen if the dissection was difficult, presents with a swollen, painful testis. A surgical site infection or a hematoma could also cause significant pain. And while it's usually later, you can never fully rule out an early failure of the repair. These are all things that have to be on my radar.
That was a fantastic, comprehensive answer. And it brings us to one last really critical point. For an adult inguinal hernia, what's the single most important factor in preventing recurrence? It's the principle that underpins the entire modern approach to this surgery, achieving a strong, tension-free repair of the inguinal floor. That is the ultimate key to success. Thanks for joining us for this explainer.